Where compassion is paramount, there exists a place that goes beyond the ordinary. It's not just about responding swiftly in times of crisis, it's about being a beacon of hope during life's most challenging moments. It's not just about treating an illness, it's about engaging your child's imagination and turning their visit into a memorable adventure. It's not just about a diagnosis. We make it our mission to ensure that you fully understand your condition while going out of our way to simplify medical jargon. It's not just about serving meals, it's about nourishing your body and soul with delicious and nutritious food tailored to your dietary needs. It's not just about maintaining cleanliness, it's about a pristine and hygienic space that promotes healing and well-being. It's not just about performing a surgical procedure, it's about meticulous planning and executing each step with precision and expertise. Our team of doctors, nurses, and support staff work in harmony, driven by the belief that exceptional healthcare is a combination of expertise and heartfelt compassion. Welcome to Clinics, where health and care meet.
Good evening, colleagues, and thank you very much for joining us. And indeed, welcome to Clinics where health and care meet. And it's always a pleasure to be in your midst every Thursday evening when we host this CPD accredited webinars. And we do not take your attention, attendance, and support for granted because you have been very loyal participants to these webinars. It shows that every week we even have high numbers. And so we're grateful for that. But we are grateful because we are able to share continuing medical education on this platform by engaging you and also inviting speakers with different expertise and interests to share their knowledge, experiences, and their journey in healthcare. And so these webinars are meant for you. I know that some of you may be, I think generally we are all joining these webinars because we want to be updated on continuous medical education to improve our skills and expertise and to be able to provide improved quality care for all the patients that we meet. And we provide care to in our various sectors, various disciplines, and various settings. And these webinars are CPD accredited and they are also streamed live on YouTube. So if you miss one of the sessions, you are quite free to go to our YouTube link and like us on YouTube, and you'll always be reminded about the forthcoming webinars. But you can also go back and watch the previous presentations. And so this evening, it's one of those evenings, and please also make sure that you do submit all your details. I've been getting queries from colleagues who are checking if their CPD points have been allocated. We upload the CPD, the attendance register to our service provider so that they are uploaded to the HPCSA within 24 hours. So on our side, we do our best. But if you do encounter challenges and problems in terms of not being sure if your points have been allocated, do not hesitate to contact us at webinars@clinics.co.za, or you can just send a query to my email, rvilla, LLBILLA, @clinics.co.za, clinics with an X. And this evening, before we start our webinar, just want to start with a moment of silence. We clinics are going through a period of mourning. And we lost our head of nursing services, Mrs. Lydia Muremi, who passed on this week, this past Tuesday, after a short illness. Spent some time in hospital the last 2 months or so, and in and out. And so this evening, we just want to convey our condolences to the family and to the fraternity at large, the nursing fraternity and our colleagues within clinics, and that we say, may they be comforted and may her soul rest in peace. So we'll take a moment of silence in her honor. Thank you very much. And that's a picture that we stopped this morning, mid-afternoon, we had a memorial service and the funeral will be on Saturday. And thanks, Kamo, for flighting that poster. She joined me one of the webinars when we were doing Nurses Day on the 5th of May, but I think 2022. And so this evening, as we continue with our webinars, we are taking a different angle. It's an ethics point webinar, and we've invited a colleague from one of our partners that we work with. I think everyone who is of different faiths of religion, Mr. Nkosana Maseko, who is the Director of Hospital Information Services for Jehovah's Witnesses. And this is part of a worldwide network of more than 2,000 hospital liaison committees. And the network that he works with provides authoritative clinical strategies to avoid blood transfusion and facilitates healthcare for patients who are Jehovah's Witnesses. And the regional office in South Africa supervises the work of the network, the liaison committee in the following countries: Botswana, Eswatini, Lesotho, Namibia, South Africa, and St. Helena Island. He's quite well-traveled and has spoken at various conferences, addressing various doctors and specialist groups. And one of these, we just mentioned two of them, is presented at the Department of Pediatric Surgery at the University of the Witwatersrand Medical School in Joburg, and also at the Anesthesiologist Society of Namibia in Swakopmund. So we invited him to come and speak to us. I remember about 4 weeks ago, we were dealing with pediatric care in our theaters and institutions. There was a question about ethics that came about Jehovah's Witness and blood transfusion. So I did indicate that we were planning on getting someone like him, and we are grateful to Dr. John Mnesi, a colleague of mine for many years, who then availed Mr. Nkosana to speak to us. And he'll be speaking about the medical management of Jehovah's Witnesses, a collaborative approach. And so we are glad to have you in our midst, Mr. Nkosana. We'll talk more about other areas because I've had encounters myself dealing with patients needing blood transfusion, and always a predicament as healthcare administrators or managers as to what do you do when you're faced with these ethical questions. So I think and trust that tonight you'll unravel these intricacies that we clinicians and administrators encounter from time to time. Thank you and welcome to Clinics Health Group's weekly webinars.
Thank you so much, Dr. Vila, for that kind introduction, and thanks for extending a kind invitation to us to come and present. And also thanks to your staff at Clinics Health Group for making this presentation possible. And we thank everyone who took their time to attend. I may just want to mention two things, maybe right from the beginning of my presentation. One is, as Dr. Vila has mentioned, I am the Director of Hospital Information Services for Jehovah's Witnesses for the South Africa branch. I'm not a medical doctor. And this presentation, as has already been alluded to, is an ethics presentation. So we will not be discussing or dwelling into our religious beliefs as Jehovah's Witnesses. Quite interestingly, one of your Leonard colleagues,
sorry, Mr. Maseko. Please share your presentation. Yes.
Okay, thank you.
Thank you.
I think it should be visible.
Yes,
So I was
it's
just
fine. Thank you.
quoting a quotation from one of your Leonard colleagues. His name is Baruch Spinoza. He's a Dutch philosopher. And when it comes to matters of cultural and religious diversity, he had the following to say. He said, I have striven not to laugh at human actions, not to weep at them, not to hate them, but to understand them. So it is also my hope that by the end of the presentation, you will understand us better as the Jehovah's Witness community when it comes to medical treatment, and also what kind of assistance we offer to you as the doctor treating one of our members that is one of Jehovah's Witnesses. This is a theme of our presentation, and we just want to highlight really the phrase about a collaborative approach, because it takes quite a number of entities in order for a patient to be treated successfully according to their wishes, within the limits, of course, of the medical fraternity. In speaking to some of your colleagues, they say this is how they feel when they treat one of Jehovah's Witnesses and a patient refuses a blood transfusion. They feel as if the doctor and the medical facility are on the other side and the patient is on the other side. So we're hoping by means of this presentation, we will bridge that gap. And we're going to do that by means of 3 objectives. So you'll notice the first part of our presentation, we're going to explain what is our position as Jehovah's Witnesses when it comes to medical treatment. Then the second objective, we will briefly highlight some of the medically acceptable clinical strategies that could be used to preempt the use of allogenic blood transfusion. And then finally, we will explain the network, the hospital liaison committees. How do they assist you as a clinician and your institution that you are working with? And also, how do we benefit the patient who has requested our assistance? So let's start with the first one regarding our position as regarding our position as Jehovah's Witnesses. So we'll answer that question, what do we believe? And here's a quotation again from one of your Leonard colleagues. In many years in treating Jehovah's Witnesses, he came to this conclusion that Jehovah's Witnesses are not anti-medicine or anti-surgery. If anything, just like anyone in the community, they seek medical attention. And that is why when we are sick or when our children are sick, we bring them to the hospital because we believe in medical science and we entrust them to the expertise of the doctors. Most of our, or some of our members are doctors, others are working in a hospital, either in management or as employees. And we believe in medicine, as I mentioned. We'd like to relate to you that during the COVID-19 pandemic, our organization took an active interest to encourage our members in our congregations to get vaccinated, because at the time, medical science had proven that it's a wise course to do so. So we were one of the organizations that were advising our members to get vaccinated. And really that attesting to the fact that we do believe in medical science. I did mention that this is not going to be a religious presentation. So we're showing you this slide because perhaps you may be wondering, but why will Jehovah's Witnesses refuse a life-saving medical treatment in terms of a blood transfusion? So our reason for refusing a blood transfusion is not a medical reason. We are not running away from the risk that blood may bring, but we have a religious reason. We are obeying that scriptural commands from Acts 15 verse 20 to abstain from blood. So when we say we refuse a blood transfusion, what do we mean? Again, you will know much better than me here because you are experts in this field. As we understand it, blood can be transfused as whole, or it can be given either one of those 4 major components. So you will notice on the slide there that a typical Jehovah's Witness patient will not accept transfusion of whole blood or any of those 4 major components highlighted in red. But we also do understand that medical science really has progressed, where out of those 4 major components, you can get fractions, certain medications like your immunoglobulins, hemoglobin-based oxygen carriers, and so forth. And you will notice what is our stand regarding that is a matter of personal decision. So what does that mean? It means one Jehovah's Witness patient may accept some of these fractions and another one may not accept them. So it all depends on the decision of the patient. And I think as doctors, you deal with patient autonomy quite often. After explaining to a patient what the medication does, what are the benefits of taking it and what are the disadvantages of not taking it? Once the patient makes a decision, then ethically, you will support the decision that they've made. So what we are pleading with you as well is that you explain, as you already do, to the patient some of these fractions and then let them decide if they will accept them or not. But now, what about procedures involving the use of our own blood? You will notice again on the next slide, under what is not acceptable, a typical Jehovah's Witness patient will not accept pre-operative autologous donation. So they wouldn't come to the hospital to donate their blood to be used later when maybe they are doing surgery or something like that. However, again, there's a host of other options which are a matter of personal decision. So again, you are very experienced and you are experts when it comes to this. Things such as dialysis, cardiopulmonary bypass, and a cell salvage machine. Some Jehovah's Witnesses may be in a position to accept those as alternatives to using their own blood. We do understand that as Jehovah's Witness patients, we carry a responsibility to inform you as doctors what it is that we accept and what it is that we don't accept, so that we make your work easier as well. So as an organization, we've developed a legal document. It's called the Durable Power of Healthcare. So this is a document that the Jehovah's Witness patient, way before they are hospitalized or they go to the hospital, will have filled it in, made research with the assistance of some members of the congregation, also get to know what options they have and so forth. So what are the benefits of this legal document? Basically, they are twofold. One is that it protects the patient, especially when they are unconscious, from receiving an unwanted blood transfusion. But two, it also releases the doctor and the institution from liability. What do we mean by that? Let's say you are treating one of Jehovah's Witnesses. They come with this card, it's on file on their hospital, and you try everything you can to treat them without blood. And let's say an unforeseen occurrence happens. Maybe the patient dies. So this document will protect you as the hospital and also as a clinician against liability because you have acted according to the wishes of the patient. But the opposite of that can also be true. If a doctor, for some reason or another, decides to override these instructions of the patient, unfortunately, we cannot rule out that the patient may take legal steps against the doctor or against the patient. Dr. Bila earlier on alluded to some also difficult situations that as a medical field you face. I remember in doing some of these presentations, especially to emergency care medicine and those that work in trauma, a common question that they always ask, they will say, imagine a scenario, I am working in the middle of the night as a doctor. The patient comes in, they've been involved in a motor vehicle accident and they've lost a liter of blood. Now they come to the hospital. How will I know if they are one of Jehovah's Witnesses? What if they don't have this card? Can I transfuse them? I would like to answer that question by 2 points. The first one is that we hope that by means of this presentation, we will have shared some information which really will serve as reminders to you regarding what can be done in some of those situations. But two, we believe that there are protocols in your hospital. I suppose the clinic's healthcare group also has got protocols to say, in these situations, what must you do? And really, you are in a better position to know what those protocols are. And when you've done everything you could, you will default to the protocols of the hospital, which will also be within the limits of the practice of medicine. So in conclusion, regarding our first objective, what is our position as Jehovah's Witnesses when it comes to medical treatment? We have established that just like any other member of the community, we seek quality medical care. The only difference is that we request that that medical care be without blood transfusion. Let's move to our second objective regarding the clinical strategies to preempt the use of blood transfusion. And really, again, this is where the collaboration part comes in. How can you, as the clinicians, assist us? Because really, you are experts when it comes to this field. You'll notice again a very interesting quotation from one of your colleagues. Dr. Steve Frank is a qualified anesthesiologist. And in one of the articles that he has published, he came also to this conclusion. Because sometimes there's a notion that if a patient is not given a blood transfusion, somehow we are minimizing the quality of care that should be given to the patient. But this study shows that treating with blood transfusion and without blood transfusion has got similar outcomes. What is more is that bloodless care is not only cost effective, but it is also of high value practice. So what are those clinical strategies that, as we mentioned again, I mean, you are experts here, you will know much better than us. They could basically be divided into those four main modalities. So the first and the very most important one, it is the minimization of blood loss, whether by surgical techniques or pharmaceuticals and so forth. The second one is enhancement of hematopoiesis. So this is where certain agents are given to the body to start stimulating the body to produce its own red blood cells and other blood cells. And maybe we could mention for a minute or two there that in working with your Leonard colleagues in different cases that we handle at our head office, they have mentioned here that the use of intravenous iron, along with folic acid and vitamin B12, these are some of the components that help to optimize the patient's hemoglobin. But perhaps you're wondering, so how long will it take to optimize a patient? Medical literature supports this fact, and also the experiences in the cases where we've been involved, is that when this IV iron is dosed according to what we call the Canzoni formula, that takes into account the current hemoglobin, the target hemoglobin of the patient, and their body weight. You can expect to have a 0.5 grams per deciliter, or half a point increase in hemoglobin every 24 hours. Now that's quite significant if you think about it, because if you have a patient with a hemoglobin of 4, and in the absence of maybe other collateral conditions, and this formula is used, you can expect a point increase every 48 hours with that patient. So how does that compare with blood transfusion? Quite interestingly, the South African National Blood Transfusion Service has got a message for the clinicians at the back of a unit of blood that the doctors should endeavor to exhaust all other alternatives before they consider giving blood. And one of the reasons why that is important is because transfused blood has got a depleted amount of 2.3 dpg. And perhaps you will remember, this is the molecule that when the blood reaches the tissues, it allows the hemoglobin molecule to release oxygen into the tissues. So what does medical literature say? It says that transfused blood, because of depleted amounts of 2.3 dpg, will not release oxygen, at least for the first 8 to 12 hours after transfusion. Now, as we understand it again, working with your Leonard colleagues, is that blood transfusion is basically given for 3 reasons. One is that it corrects the volume. And 2, it provides clotting factors. And perhaps the most important one is oxygenation. But as we have established now is that if a patient is transfused now, the oxygenation part will only kick in from the first 8 to 12, after the first 8 to 12 hours. So we're just mentioning it, that fact, because when you compare it with the modalities of enhancing hematopoiesis, you can see there that, as Dr. Steve Frank, in most cases, you may have similar outcomes. The third point is about autologous blood management. In our previous slide, we did show you that some of Jehovah's Witnesses will be amenable to using a cell salvage machine and other modalities. So this could be explored. And when all else is done, the tolerance of anemia is quite key. Multimodality approach is a very important concept as well in medicine, as we are told by your Leonard colleagues. And there was a study, again, this article was published by Prof. Arya Shanda, and he has shown there that when these modalities are used together, there was almost an 8 units amounts of blood that have been saved. Doctors that work in surgery will know that better, because sometimes it happens that the patients are transfused pre-operatively, intraoperatively, and post-operatively. So looking at the collective results of using alternatives, these are the savings that have been discovered by this study that was conducted. A multidisciplinary approach is also important because, yes, the surgeon has got to work very closely with the anesthesiologist, but the nursing staff also has got an important role to play, especially when it comes to phlebotomy. Because if a patient comes to the hospital with a hemoglobin of 4, taking regular samples of blood rather than maybe using the pediatric ones for those tests that will be able to do so, maybe a huge saving. So having a multidisciplinary approach, even including a hematologist at some point, it's something that works quite well as well. Doctors that work in trauma or emergency medicine will be familiar with that phrase that time equals life. And in this study, again, that was done, you will notice there that when surgery is delayed, look at the mortality rate, it's high up there with 75%. But when surgery is done within 24 hours, even in trauma cases, yes, there is still mortality, but look at a huge reduction that happens or has been proven by some of these studies. In a study that was done by the Western Australian Patient Blood Management Program, which was done over a period of about 6 years in about a number of public institutions, there was an overall decrease. Look at mortality, infection, acute myocardial infarct or stroke, as well as the length of stay. This is with treating with alternatives as compared with treating with a blood transfusion. And when it comes to cost as well, maybe as a clinic scope, I don't know how much that will affect you, but from time to time, we engage with CEOs of public hospitals. And in our meetings with them before we present to the clinicians, they will always tell us how much of a budget of a hospital is allocated for giving blood transfusions. And so those modalities that we spoke about, when the hospital has enough stock of them, then you can see the huge savings as displayed on this slide. We are often invited from time to time. Sorry, is my PowerPoint still showing, Gamo?
No, it's not showing anymore.
It's not showing. My apologies. Let me quickly
it just
correct that.
disappeared as you were going to, yeah. It's loading.
Okay. Is it showing now?
Yeah, sure.
Sorry about that. Okay, we'll quickly go to that slide. As I was mentioning that from time to time, some other hospitals or specific departments will invite us to their M&M meetings or CPD accredited meetings. And when it's a specific specialty, as you can see there with the different medical disciplines, we will then dwell into some of the case studies and relevant information. But as I understand it, the audience here today is from different medical disciplines, so we wouldn't choose any of these ones. So in summarizing our second objective there, when it comes to these strategies, I think we've highlighted that they are evidence-based strategies that could be used to avoid blood transfusion. Now let's talk about the last part of our presentation, the Hospital Liaison Committee Network. How can we assist you? And again, another quotation here from one of your Leonard colleagues. You will notice there he said, in working with the HLC, he's realized that this minimizes any legal or moral conflicts. And perhaps this is quite an interesting subject when it comes to pediatrics, because oftentimes the doctors will ask and say, well, you as a parent, you are a Jehovah's Witness, but how do you know that when this child grows up, will also take upon your beliefs, including refusing a blood transfusion? Now, South African legislature, which is deemed to be one of the most progressive in the world, answers that question quite well, because in Section 129 of the Children's Act, it does acknowledge that as a Jehovah's Witness parent, I cannot refuse to give consent for medical treatment, including a blood transfusion, only because of religious beliefs. But in 2005, that Section 129 was amended, and it included a clause to say, unless that parent or guardian can show that there is a medically acceptable alternative choice. So why is it an interesting piece of legislation? It's true, it doesn't give the parent 100% consent making, but neither does it give the doctor to do the same. So the doctor is ethically obligated to exhaust the alternatives that are acceptable. And I will tell you an experience that we deal with these pediatric cases quite often in our head office. Sometimes some of the doctors will quickly go to court to get a court order. And when the family is given an opportunity to defend it, then the judge or the magistrate will render his judgment based on Section 129. So one of the questions he will ask is that, can we say that there are no medically acceptable alternatives in this case? And in some cases where, as I mentioned, it's not all of them, but some of them, where maybe the doctor went premature to court, the judge actually gave a conditional court order, directing the doctor to first of all exhaust the alternatives, and only if they fail can they give a blood transfusion. So how does the Hospital Liaison Committee come in? Is that when they come and share this information, we may, in most cases, avoid situations where the doctor will have to go to court. Obviously, we do understand this is not a blanket, what you call modality. In some cases, as we mentioned earlier, there are protocols in your hospital, especially on emergencies, as to what you can do. But by far, quite a number of cases, they could be resolved without really using this modality. So hospital information services, we mentioned earlier on that the office in South Africa is just one of 86 offices worldwide. We are operating in 6 continents. We have over 2,000 hospital liaison committees. There are 50,000 trained hospital liaison committee members who will liaise between the doctor and the patient when invited to do so. On our database, we also have a list of experienced physicians. The vast majority of them are not Jehovah's Witnesses themselves, but in working with witnesses and other patients who refuse blood for certain reasons, they have acquired a skill to treat without blood. So we have an agreement with them where we can have a consultation between the doctors. Maybe a doctor is treating a patient in that situation for the first time, and after accepting what the HLC has got to provide, they may need to compare notes with their colleague who's done the same surgery or procedure. Then we can facilitate that service between the HLC, the doctor, and the treating doctor. So what is the role of these hospital liaison committees? It's 4 roles that they do. Number 1 is presentations like this one, where we are raising an awareness, and we see the value in doing that, because then we can share with the doctors this information. There's also an opportunity to ask questions, so that when patients are now admitted at the hospital, then we don't waste time answering some of those questions that could have been answered, but we focus on the medical treatment of the patient. We also do that consultation where the 2 doctors can compare notes regarding the patient. So we facilitate that service here at our head office. Medicine is one of the interesting professions. In fact, one of the quotations from one of your Leonard colleagues, he said, "I care more particularly for the individual patient than for the special features of the disease." And if you think about that, caring for the patient as an individual, the patient has got the emotional aspect, the psychological aspect, the religious aspect, and the list really is endless. And medical science proves that when patients feel that all of these are being taken care of, they recover quite quickly than the patient who may otherwise get the best medical treatment, but maybe their emotional needs, their cultural needs, their psychological needs are not being met. So one of the roles of the hospital liaison committee is that within it, we have what we call the pastoral visitation group. So these are trained members. They are not there at the hospital to proselytize to other non-witness patients, no. They are only there to give some spiritual support, emotional support to the patient. So from time to time, we engage with hospital management to see how can we work together with their protocols, so that while the patient is getting best medical care, they are also feeling that they are well cared for when it comes to their religious needs and also their emotional needs. And finally, we provide resources. Later on in the last slide, we will show you a URL and a QR code to our website, which is dedicated to non-blood management. And there you will get articles, well-researched. Our World Headquarter Office renews these articles from time to time. And they either talk about procedures, pharmaceuticals, or answer some of the ethical questions when it comes to treating without blood. That is the address. If you type in jw.org/medical or scan the QR code, it will take you straight to our website, where you will be able to get these resources. So in conclusion, this collaboration, as we mentioned, medicine has evolved. It's patient-centered, isn't it? And as you can see again, the patient is right at the center of their medical treatment. As clinicians, you are playing a very key role that we all appreciate. The administration of the hospital, we spoke about the forms that the patient will fill in to raise awareness about what they will accept and what they won't accept. So the administration of the hospital has got a role to play. All we are pleading again is that when it comes to Jehovah's Witnesses, please include the hospital liaison committee in that part of the triage of the collaboration, because not only will they benefit the patient, but they will also benefit you as the clinician and the institution that you are working at, in order to care for this patient according to their needs within the limits of the practice of the ethics of medicine. So we've highlighted that this is a worldwide assistance for physicians and also the patients. Thank you so much. That is the end of our presentation. We will hand back over to Dr. Bila.
Thank you very much, Mr. Maseko. It's been quite an interesting conversation and presentation that you've shared with us. I wish I'd known you some years back. One of the questions that you raised about pediatrics, we had a patient, similarly a child, and I recall that we also went to court many years when I was still at taking the fact that we say that the child belongs to, in terms of the Health Act, the child does not belong to the parents. Actually, in that instance, it belongs it belongs to the hospital manager or in terms of I think that's the superintendent or the clinical manager head of institution. So it was under that understanding that we had to go to court. But you say that I think that was just before 2010 or so. That is after 2005. Perhaps we were a bit ignorant about the changes in the act at that time. But have you found that situation there's a better understanding or there's better collaboration? So there are hospital liaison committees that doctors or hospital administrators are not too quick to go to court. So they have that understanding. Your comments. I've seen some questions related to pediatrics in particular.
Thank you so much, Dr. Bila, for that question. Maybe we just quickly share that section 129. Just a minute. Can I ask Kamu to allow me to share one slide?
Yeah, Kamu, can you allow Mr. Maseko to share the slide?
Okay, thank you so much. It's still not being able to, oh, there we go. It is visible, Dr. Bila?
Yes, it is visible, yeah.
Thank you so much. So that is the piece of legislation that I referred to. You will notice there, I mean, it was, as I mentioned, it was amended in 2005 because prior to 2005, it used to say no parent or guardian or a child may refuse to assist a child in terms of subsection 3 or withhold consent in terms of subsection 4 and 5 by reason only of religious or other beliefs, and it ended there. But in 2005, the latter part was included to say, unless the parent or guardian can show that there is a medically accepted alternative choice. So the point I was alluding to, I mean, we are not villainizing going to court. It's a provision from the legislature. But I was just speaking about going to court prematurely, where maybe the doctor doesn't want to work with the HLC in terms of these alternatives. And when they get to court, we've had a number of cases where a conditional court order is given to say, try those alternatives first, and only if they fail can you give blood. There are exceptional circumstances you've mentioned. Sometimes when there's an emergency, I believe according to the protocols, the doctor can liaise with the superintendent of the hospital and they transfuse the patient. It's a provision that is there. However, I think if the parents were to investigate that further, they will want to find out that it was a real emergency. I hope that answers the question.
No, thanks. It does. Yeah, I think we'll also go back to the reference that you've provided. There's a question now. I think it's a bit too personal. It says, I think that's what this is. It begins with, it's a personal question. Let's say you are in a coma and need blood. Doctors don't know who you are. You're a Jehovah's Witness. The following day you wake up healthy. How would you feel after finding out that you were transfused?
It's a very interesting question, really. And speaking on behalf of most of Jehovah's Witnesses, because I did mention in the earlier slide that, we're not refusing blood transfusion for medical reasons. It's one of our core tenets of our faith. So if a patient were to wake up, they will feel, especially if they did everything possible to make sure that the doctors know that they don't want blood, they will feel violated. However, in cases where maybe there was no indication and the doctor tried their best, I think really the responsibility is for the patient to let the doctors know that, look, should I be in a coma situation, under no circumstances I want a blood transfusion.
We're living in quite a litigious state or situation now. Supposing the patient wakes up well, they are fine and well, but they say, as you use the word violated, can they start sue the doctors who gave them blood at a later stage, even though they survived? Or have there been such instances?
They may. We can't rule that one out. And maybe if I could relate also as well, in one of the platforms when I was doing this presentation, one of your colleagues asked the same question, and I said, you know, it's quite interesting because as doctors, you deal with these difficult situations quite often. Let's take, for example, a patient that has been diagnosed with cancer. Now, medical science says, well, this patient, the recommended treatment is chemotherapy. So as the doctor, you have to explain to them what that involves. You will have patients who will still say, no, I don't want to go through that experience. And you respect what they have decided. So with blood transfusion, it also has to be the same, because just like chemotherapy or any other medical treatment, the patient has got to give their consent. So in that case, it will depend. Some patients will feel violated. They'll take legal steps against the doctor. And so we can't rule that out.
Sure. Scary. Is erythropoietin permissible? Dr. Polokov wants to know.
Sorry, Dr. Bill, I didn't get it.
Is erythropoietin, is it permissible?
Yes, by all means. So it will fall under one of those fractions because it is made from blood. That is true.
Yeah, this one from Manake Mokoni. It makes a point. I wonder who makes decisions for the Jehovah's Witnesses. Should be careful what the Constitution say about the right of the child, whose interests vest with the judiciary, and say the judiciary will have to pierce the veil and hold those who make decisions that may negatively affect the child. I don't know why he says, watch this space, I'm coming for you.
I hope the answer we provided earlier about that amended section really address it, and we understand the emotional aspect that comes with children. It's
when it won't come for you. There's another question you don't see this sent to me directly. It says on the document, the durable power of attorney, even the pre-donating for later use is not permitted. Please clarify the reason for that, there's no pre-donating your blood.
Thank you so much. Yes, so as Jehovah's Witnesses, we will not donate our blood to be used by someone else or even us. However, so in other words, let's say now a patient, as it usually happens, maybe they are going for a major surgery. And the doctor says, okay, since you wouldn't accept blood transfusion, why don't you come donate your own blood? Let's keep it and then we'll transfer. So that will not be acceptable. However, intraoperatively, like with the use of a cell salvage machine, sometimes the patient is bleeding on the surgical table. Some patients will accept that, no, I want that blood that has been bled to be taken into a cell saver, washed, and then put back again into me. So it is a personal decision. It's just that with pre-operative autologous blood donation, we don't do it, but some other intraoperative modalities, that is where it's a personal choice. Some patients may accept those.
Yeah. I hope you can hear me. It looks like my internet is a bit unstable. I think we'll dealt with this question about, the children, because this other person wants to know whether would you expose your child and refuse the child to be transfused when she's shocked and needs urgent blood transfusion with a very low HB of 4.
Did they say whether I will refuse the child?
Yeah, I think people are becoming personal. I want to know from you, your own standpoint.
Oh, okay. I'm not sure, Dr. Bila, if I understand the question. So is the question that if the child needs a blood transfusion, if it was my child, will I still refuse it?
Yeah, the one, your child. I think they're trying to check if whether you stand by your own convictions.
Yes, by all means, I will refuse it for my child. I will be very much active in being interested what alternatives may be used and let those be exhausted.
Yeah. Now there's one from Rostov. Yeah. Can you hear me?
Yes, I can hear you.
You can still hear me because it looks like you are fading while I'm fading. Yeah, it says, thank you for that talk. What are the consequences for the patient should they opt to rather have the blood transfusion? And once all options are exhausted, what conversation do you have with your members around the death and consequences for relatives that are left to deal with death? If someone says, you know what, I'm a Jehovah's Witness convert, and there are no other options, but I will go for the blood transfusion.
Yeah.
What conversation do you have with such a person and also the family?
Thank you so much. So I think, as I explained earlier in the beginning of the presentation, that we really don't want to dwell into the religious side of the presentation. However, just to alleviate that concern, we do have those cases quite a number of times. And we will really, because sometimes, and in most cases, these patients are pressured to accept blood transfusion against their wishes. And so in that case, we will give that patient the support, the emotional support that they need. We do not ostracize those patients because we feel that what has been done to them, being pressured to accept an unwanted blood transfusion, was a violation of their rights. Regarding the second question about, if a patient had accepted the blood transfusion despite all avenues, I'll just make maybe an analogy. Most of the doctors here today, they work for the clinics group. Now, before you are an employee, surely there's a code of conduct or certain things that you want to obey. And the question is, if you break one of those laws, what happens? Does the clinics group discard you? No, they will find out what happened. Here, if whether you'll repeat that again. And so a Jehovah's Witness patient, it's also the same. They are not refusing a blood transfusion because they are following the orders of the church. No. Before they became one of Jehovah's Witnesses, they studied, they understood that this is one of the major tenets of the faith. And so voluntarily they do that. So in that case where they will accept the blood transfusion, just like in that analogy, we will look at what happened and give them the support that they need.
Yeah, sure.
But that is in no way to say, the doctors could then transfuse the patients or force them to do so, because that will be quite an unethical behavior. And I think there could be consequences.
Just like you must respect the wishes of the patient and respect the fact that the Jehovah's Witnesses, there are certain beliefs they have about blood transfusion. And yeah,
that's correct.
Ethically, you're bound to go according to their beliefs. The issue of I think the QR code and references, the QR code, will it work with if it's part of your slides that you give us, and colleagues can scan it from the slide presentation? If you're going to be able to share the slide presentation, will it work? Because
it should. Let me try to share it. I think it should work. Maybe you can.
Maybe leave it a little bit for a few minutes, but people can scan it. Yeah. And also the liaison committees, I think what we'll do, you'll give us the information where they can contact the HLC for Jehovah's Witness. We'll share that information with all those who are connected.
I've displayed it there on the slide. I don't know if it's visible.
Yeah, it is visible. Yeah, I think the contact numbers and the information where people can contact you, and the contact numbers and cell phone, and also the email address is there for people to check. There was a question that what happens if we've got people from the mother is a Jehovah's Witness, and the wife is, and the husband is not, and they've got a child who's got to give a blood transfusion. What do you do? How do you balance this?
It's a very interesting question. I think from the perspective of the medical fraternity is that the doctor only needs consent of one parent in order to give medical treatment to a child. Yeah. And here from our side, really, this is where we pleading to your ethical conscience, if I may put it that way. Because remember now, this child, earlier on, we mentioned one of your colleagues saying that, when they treat the patient as a whole, holistically, not just looking at the disease. Now, as doctors, practicing family medicine, you know that a family unit is very important, not only to the child, but to the parents as well. So what we plead with you to do is that whatever decision you will take, it may be good within the confines of medicine, of course. If you can do something that will please the both parents, that's good. In some instances, what has happened is that one of the parents is not a Jehovah's Witness. One of them is, and so the HLC gets involved, shares the alternative with the doctor, and it works. In some situations, unfortunately, maybe the parent who's not a Jehovah's Witness gives consent. And I think, as I mentioned, from the medical point of view, that's all that you need to get the consent to administer blood or any other treatment.
If the father says he's a Jehovah's Witness, says no, don't transfuse, the mother says yes, and the doctor doesn't transfuse, and the child does, what do you do? How do you deal with that situation, conflicting situation in the family, and they've lost the child?
Yes. Maybe I should also mention, Dr. Bila, that as an organization, we don't make decisions for the patients. As a matter of fact, we only get involved when the patient says, I am in hospital, or one of my children is in the hospital. Can the HLC be involved? And the reason the HLC is there is with the understanding that, okay, we're going to share some alternatives with the parents. But if they decide otherwise, really it's a personal decision that it's not our place to decide, especially with families. We respect the family unit. If the father, who's not a Jehovah's Witness, gives authorization, it is out of control of the other parent. And if the other one feels that they want to take legal steps, really it is something that they do. As an organization, we wouldn't be encouraging them to do a certain thing, but we will be saying, if you want us to assist you in terms of alternatives, we are there to see what we can do.
Yeah, I think there's a lot of sharing of information and education. That we come from different backgrounds, and I can see from the questions that we're still battling and with how to handle this information that is coming through from the colleagues who are and saying, I think there are two questions that could be related. One is that you're saying that the medics, the doctors at the hospitals should adapt their protocols to be in line with what the community of the Jehovah's Witnesses believe. Why is it not possible that you can also adapt your beliefs and comply with the protocols and ask for forgiveness? Linked to that, there's another question that says, if you have so much faith, so much steadfast in your faith, why not have your own hospitals for Jehovah's Witnesses patients?
Thanks, Dr. Villa. Very interesting questions. So with the first one, let me just clarify. We are not saying that the doctors must change their protocols to fit with Jehovah's Witnesses. No. What we are saying is that within the confines of your protocols, if you can accommodate the wishes of the Jehovah's Witness patient, just like you will do with a Muslim patient, with a patient that practices traditional medicine or whatever, we are saying do that if you can. No, we are not here to change the medical profession. No, we are just pleading to say, as far as the limits of your protocols allow you, we ask you that you do that. The second question about why don't we have our own hospitals? There is no need really for us to have our hospitals. I've shown a slide earlier on that we've got more than 100,000 doctors, that most of them are not Jehovah's Witnesses. In some countries, we even have hospitals that are dedicated to non-blood medical treatment, not for Jehovah's Witnesses, for patients who refuse blood for certain reasons. Funny enough, in one of the presentations that we did, we just asked the doctors at the end of the presentation to say, after Jehovah's Witnesses, one of the second greatest community of people that wouldn't easily accept the blood transfusion is doctors. So patients have got a choice about what medical treatment they want and what they don't want. So patient autonomy is very important. So we wouldn't want to have our own hospitals just because of that. Some other patients refuse blood for other reasons, not like the ones we have. Others refuse certain treatments. And so that's the complexity of the medical field, I suppose, if I could put it that way.
Yeah, I think so. Patient autonomy. I think patients refuse treatment for a variety of reasons. And others, it's lack of understanding at that moment. Perhaps they need time to absorb information, and it's shock. And I think that's why we need social workers also to work with patients, to be able to help them understand the need for a particular treatment modality. And what is the position of the Jehovah's Witness in terms of organ donation? I think one of the questions. I know that we had this question, a similar question raised a few weeks back when we did organ donation. And somebody raised a question about Jehovah's Witness, and I said, wait until we have the session. Now we have the session.
Very nice. In one of our leaflets that you will download when you go to our tab, it addresses, it's got a title, Religious and Ethical Position, and that exact question is there. But to give an answer briefly, it's a personal choice. Other Jehovah's Witnesses will freely accept an organ transplant. Others will not accept it. Just find out from the patient if they will accept it or not, just like any other form of treatment. We have no inhibition with organ donation, such as we have with blood transfusion.
Yeah. There was a question about litigation. I think the question is not if a parent chooses for his or a child to receive blood transfusion and the child dies, can the parent be charged for culpable homicide? Murder says the parent is responsible for the cause of the death by withholding treatment for the child.
I will not say for sure. I think really it will be the authority of the court that will determine that, looking at all sides and all of that. Maybe I may just relate this experience. I remember some years ago here in our head office, it was a private hospital. I wouldn't mention it by name. The doctor prematurely went to court with a pediatric case. And when he was cross-interrogated by the legal team of the parents, they asked a very important question to the doctor. They said, "Doctor, can you give us and these parents a guarantee that if blood transfusion is given, this child is not going to die?" And I think out of an emotional moment, the doctor said, "Yes, I do that." You know, later on in our relationship, that doctor faced a disciplinary hearing in their hospital because that was an incorrect statement to say. So why am I mentioning it is that as much as we are saying the patient may have died because they haven't been given a blood transfusion, equally so, we have a number of cases where patients were given a blood transfusion and they still died. So I think really the answer to that question will be the determination of the court when they look at all aspects to see, was this parent reasonable? For instance, were they saying no blood and nothing else? Or were they actively seeking alternatives? And also the fact that, you know, if a parent takes the child to the hospital, that on its own is an indication they want the best medical treatment for that child. If they didn't want medical care, they would have kept that child at home. So sometimes the confusion is there between a refusal of treatment and a refusal of a certain aspect of treatment. And I think I will close by saying that the court will decide if that parent could be charged with negligence or not.
Yeah, I think the court best maybe it depends on who will, in the first instance, press charges, because I mean it is your child. Will it be? Yeah, it's but I think I think the answer is correct. We're running out of time. Lots of questions that have come, but other questions that I've seen have been answered, and I would refer colleagues to the resources and the references that you made available to answer those questions. Because I think there are lots of questions about children and refusal to get blood transfusion in the modalities. And I think that was at the beginning you did show that there's certain positions that you have and that alternatives are there. Like I think I'll just leave with this one and ask Samakunyane to make a final closing remarks. It says, excellent presentation, bloodless medicine is far superior to blood transfusion. There are many risks associated with blood transfusions. Lots of literature showing a blood transfusion leads to immune suppression, increasing the risk of infection, worsening the outcome of cancer surgery, etc. This is from Peter Stewart. Perhaps I'm not sure if you know Peter Stewart, but I think someone who's an advocate for bloodless surgery. I'm going to ask Professor Makunyane to do the closing remarks before we come to the end of this session.
Thank you very much, Dr. Bila. On behalf of Clinics Risk Committee, I would like to express our gratitude for your presentation, Mr. Maseko. A really controversial and highly emotive topic, I must say. But this has really been an eye-opening session and has provided invaluable insights for all of us in the medical fraternity who manage Jehovah's Witnesses, the patients. And the information shared today will undoubtedly enhance our collaboration and help perhaps minimize the dilemmas we often face, especially during emergencies. Your suggestion to invite you to our M&M meetings is good, and we welcome a solution-oriented approach to such challenges. Thank you once again for your valuable contribution. To the clinic's health management team, I would like to once more extend my sincere condolences on the loss of one of your longest serving and most crucial members. Thank you for still being able to put together this webinar. And to all attendees, your participation in this webinar has been invaluable. Thank you very much. And now I hand over to you, Dr. Bila.
Thank you very much, Prof. Makunyane. Someone wants to see your face. They think that the slide is pretty, but I don't think you had switched on
my slide is disabled.
your video. Dr. Abnisi was the one who helped us to get in touch with. No, it's okay. I think Dr. Abnisi just wants to see Prof. She's always with us, yeah. I just want to say thank you very much for Mr. Maseko for being here with us, and colleagues, thank you very much. Prof. Makunyane has done the closing remarks. I do not want to repeat all that, but we just want to thank you, and we hope to see you again next week when we continue with our weekly webinars. And thanks to Kamu, Anza, and Sistoko for the support always doing the work in the background. Good evening, colleagues.
Bye.
Thank you. Bye.
Thank you.
Bye.
Bye-bye.
Thank you very much. Enjoyed.
Bye.
Bye.